basically giving lumbar plexus and sacral plexus block. This is an old lady and she has fractured trochanteric. So we have planned lumbar plexus as well as sacral plexus. There are various techniques and points described for lumbar plexus as well as sacral plexus. I'll be first elaborating some of them. Okay. Basically the intention in lumbar plexus and sacral plexus is to catch the nerves of the supplying the sensory supply to anterior compartment as well as posterior higher up in the gluteal region and above at the lumbar plexus. So what we will do is, here we have marked the spinous process. This line is the line joining all the spinous processes. This is L4, this is L5 marked here. We have taken the iliac crest. How do you see the iliac crest? Press inside and this becomes the iliac crest. Take a line from there, drop it perpendicular to the line you have already drawn. This is the joining point of these two lines. From there you take 4 centimeters. I have marked it here. You take 4 centimeters, draw a line parallel to the line joining the spinous processes, and the intersection becomes the point of insertion for the lumbar plexus block. This is my point of insertion. Okay, and if you follow this technique, this is called the Kynes technique. Okay, there is another technique where you take the iliac crest and come to the posterior superior iliac spine. This is the prominent structure felt here. This is the posterior superior iliac spine. So supposing you draw a parallel line along this, see, parallel to this line, if you draw a line and the point of intersection, this point of intersection with this line, if you take this point of insertion for lumbar plexus, then that will be called the Venice technique. This becomes quite lateral, so it is generally not followed. The advantage of Kynes is that it is almost corresponds to the lumbar plexus area. It is also known as Swas block because we go in the Swas muscle. Okay. But even better technique is the Capdevila technique. In Capdevila technique, what you do is you draw a line as Veni joining the posterior superior iliac spine, which runs parallel to the line joining the spinous process, and then from there, this point to this point, divide into 1/3 and 2/3. This is basically 6 centimeter, and if you divide, it is 2 centimeter and 4 centimeter. In our case, it is corresponding with the 4 centimeter mark. So no difference between Capdevila and Kynes in our case. This is for lumbar plexus. So what do? Go perpendicular from this point and try to hit the transverse process. After hitting the transverse process, you walk over either cephalad or caudate. Go 1 to 2 centimeter deep, never beyond that, and your target is to elicit a quadriceps response. Quadriceps response will be seen here, and you will see the patellar dance as well. So the thing is that ideally you should get that response at 0.5 milliamperes of current. So you start with 1.5 milliampere start and then come down to 0.5 milliamperes. If you get the quadriceps response, deposit the drug 15 to 20 ml or 25 ml. It can be for anesthesia purposes as well as for analgesia purposes. The thing which should be remembered is that it is a high level advanced block and complications can occur if you are poking too many times, because you have arteries around and it can be dangerous if you enter into the sheath, dural sheath, because it lies very close. Okay? So you should always keep an intention to go laterally rather than coming medially. Never try to come too close. You can produce an epidural block. This is one point to be remembered. Okay? The other thing which we will do is a sacral plexus block. So how do you do a sacral plexus block? We will be following the Monsour's technique. Okay? Monsour's technique mein we mark the posterior superior iliac spine and run a line joining the iliac ischial tuberosity. Okay? Most dependent. This line is joined, and along that line you take 6 centimeter from this and go perpendicular to skin. Again, target is to elicit a common peroneal or a tibial nerve response in the branches of sciatic, which can be seen as a dorsiflexion or a plantar flexion of the foot and toes. Okay, this is about Monser's technique. Here also this is will be a deep block, so all the complications can happen here also, so one should be very careful, and it should be planned, or you should go for this block only when you have given several of the less dangerous blocks. This is advisable only after you have got complete confidence. Okay, that's all about the technique part. Then we will demonstrating the block subsequently. Okay, pause. Starting the technique. This is a 10 centimeter long stimuplex A needle. Okay, and the point of entry will be already marked here, 4 centimeter, which corresponds to 1/3, 2/3 also. The entry is perpendicular to all the skin as well, and it is a deep block, and this is a lean thin patient, so I expect from around 3.5 to 4 centimeter, and then one should never cross the 2 centimeter after you have hit the transverse process. So let's begin. I have hit the transverse process and I am going little deep. I am feeling the transverse process here and I have walked over it, just gone beyond it, and this is the quadriceps response. See, this is the quadriceps response. Show the needle position. I have got cephalad over the transverse process after hitting the transverse process. Current is at 1.5. Now reduce the current, and it should not be beyond 0.5. Again, see the response. At 0.5, is it visible? At 0.5, increase the current. Increase. This is visible at 1. So we can go a little more. Is it visible?
No, sir.
Ravi?
No, sir.
Visible? 0.8 still visible. 0.7 still visible. 0.6, it is disappearing at 0.6. It's okay, acceptable, and we'll see. Important thing is this is open to air. This is open to air. So supposing if there is CSF or some leak, then it will be evident. So one should not connect with the syringe. So I am at the right place. At 0.6 I am getting. One should not get below 0.5 also, because that would mean you have entered the dural sleeve. Aspirate and see whether it is going freely. Okay? That's all about the block. I will deposit 25 ml of drug here. Okay? Thank you. Okay. Now we are demonstrating the parasacral block. So we are inserting at 6 centimeter down the posterior superior leg spine. Target is perpendicular, going perpendicular to the skin, and let's see. We are expecting to get at around 3.5 to 4 centimeter. Around 3 to 4 centimeter, and we have got the plantar response. Okay, and this is at 1.5. Please reduce the current, and let's see whether it is visible at 0.5 also. Reduce to 0.5, 0.48, and it is still visible. Okay, so this is the ideal response we are expecting at parasacral. Now reduce it further to see, confirm whether we have not entered intraneurally. Go closer, and at 0.32 still visible. Reduce further at 0.24, it is not visible. Come back to 0.48, and at 0.34 only itself it has started. So we are at the ideal place and we can inject. So just see what happens by injecting 1 ml. Aspirate and inject just 1 ml and it has disappeared. This is the right sign. Now we will inject 15 ml of local anesthesia and our parasacral block is done. Okay? For the time being, this will give anesthesia to the whole posterior compartment. By giving lumbar plexus and sacral plexus, you can give anesthesia of the whole limb, including hip joint. So you can get a hip surgery done with lumbar plexus and sacral plexus club. Thank you.